Without further ado, I'd like to introduce Dr. Chris Critoph, who's a consultant cardiologist here in Bournemouth, who I met a few weeks ago when I went to see him about my atrial fibrillation and a few other issues, and I wanted him to give me a clean bill of health to do my triathlon that I did last week. And while I was there, I cheekily asked him if he wouldn't mind coming on and doing a webinar with us, and he very kindly and graciously agreed to. So, Chris, welcome to you.
Thanks very much.
Good. So we'll crack straight on, and I want to ask you first of all, Chris, about atrial fibrillation. This appears to be something that many of us in the WM world suffer from. What is it? Do we need to be worried about it? And why and how can it be dealt with?
Sure, no problem. Well, firstly, thanks for the invitation to speak. I've done not necessarily with Waldenstroms, but done a few sort of patient-facing talks and things over the years. I did quite a big diabetes one locally recently, and I think it's really important because the more patients are informed about their medical condition and indeed their friends and relatives and so on, I think the better outcomes people get. So I'm always happy to give up time for interested people. So firstly, I've sort of broken down, I've made a few notes as to what to talk about. With atrial fibrillation, firstly, it's a very, very common heart rhythm problem, and probably the commonest heart rhythm problem. So the sort of lay term we use is arrhythmia, which just means abnormality of heart rhythm. The heart rhythm is quite well governed, and so I always tell patients, and I probably told you, that the electrics of the heart, I always like to think of them a bit like a circuit board. So if you imagine a circuit board with solder on and then the plastic bits, and typically speaking, the electricity is carried in the wires. Now there are some chambers in the top right hand corner of the heart. In fact, I don't know how well this will work, but I just wanted to get there's a picture up. Let's see if I can do this. No. I don't think it's going to show. No, not. I think so. I've only got one screen. It just shows my. Let's just try this. Can you see that? Okay.
Yeah. Yeah.
Okay. So here is a heart. And the wires aren't shown on here, but typically the heartbeat starts up in this chamber here. This is the top right-hand corner, called the cyanoatrial node. And there's a group of cells here that they fire off at 50 or 100 or 120, whatever the rate is that you need in order to do the activity that you need to do. The electricity then travels down through the heart muscle, and you see this sort of lighter pink bit here. This is called the interventricular septum, and there's a wire basically that runs down the middle of this, gets to the bottom, and then once the electricity hits the bottom, it fans out from the bottom in another series network of wires. We call this the His-Purkinje system, and as the electricity passes through the heart, it causes the heart to contract, in the same way that if you I don't know, put your finger in an electric socket and your muscles will spasm, low voltage electrical current traveling through the muscle causes it to contract. And so that, as I say, that process just repeats itself over and over. Now, if you look up here in the top, this is the top left, it looks like this to right, but it's the left as it sits in your chest. This is the left, called the left atrium, and this is the problem area where atrial fibrillation occurs. Now, you'll see here, you can just see two of these, the pulmonary veins. So there's one here, and you can see two on the other side, but these drain around the back of the heart and they empty into the left atrium. Now, the pulmonary means lungs, and so the pulmonary veins take blood full of oxygen from the lungs to the heart. So the blood enters this chamber, it comes through this valve here called the mitral valve, comes into this is the main pumping chamber of the heart now. This is called the left ventricle. The left ventricle squeezes and the blood comes up here and out into the aorta and goes off to the head, neck, arms, legs, and so on. Now, in people who get atrial fibrillation, in the majority of cases, the area at fault is the junction where the pulmonary veins enter the left atrium. And so where they're plumbed in, these areas here, so these 4 circles, can become electrically active. And so instead of contracting in a nice synchronous fashion, these fire off a whole bunch of extra impulses that cause the heart to fibrillate. Now, in doing so, one of the main issues with atrial fibrillation is stroke, and I'm sure you'll be aware of this. And so that's where some of the public health messaging comes from, is to recognise atrial fibrillation and thin the blood down if so, and I'll come on to that in a second. And the reason it's an issue is because it's not shown on this slide here, but there's an extra structure on the side of this called the left atrial appendage. And that left atrial appendage doesn't really do a great deal, to be completely honest. It's a bit of a remnant, but I use the analogy of a slow-moving stream. So if you have a stream that doesn't flow fast, then you can get silted up, and in the same way that if the blood is not ejected through the heart quickly, this little ear-shaped structure can get a clot within it and ping off to the brain and cause a stroke. Stop showing that for a second. So atrial fibrillation is an irregularity of the heart, typically caused by an electrical problem at the junction of the veins that transport blood from the lungs to the heart. Now, when those veins start firing off these extra impulses, the normal mechanism that I talked about before with this cyanoatrial node, that becomes interrupted, and so the heart is no longer under the sort of checks and measures and balances that it normally has. And so, typically speaking, people with atrial fibrillation will have a slightly faster heartbeat, but it will also be erratic and irregular. It's incredibly common. It's increasingly common with age. So to put some numbers on it, by the time you're 80, about 1 in 5 people have got atrial fibrillation. So it's incredibly common in the normal population. And it's even more common in people who have got other structural heart problems, whether that's previous heart attacks, or they've had heart surgery, or a leaky valve, or amyloid, for example, which we'll come on to. The mainstay of treatment is recognition of what the stroke risk is, because obviously, you know, a stroke for most people is if not terminal, can be a very disabling event. And so we try and we call risk stratify patients, so work out who within the group of patients that we see are the most likely people to have strokes. And in those people, we offer blood thinners. And so the risk increases with age, and there's basically a scoring system. So the older you are, female gender, having a structurally abnormal heart, high blood pressure, diabetes, having had a stroke before, all these things sort of increase your risk. And then we use an algorithm essentially to work out what your score is. And if it's above a certain threshold, then we think about thinning the blood down. The people, in terms of symptoms, say they'll often feel an irregularity of the heart, or palpitations is the sort of commonest word we use. Palpitations really just means the feeling of the feeling of the heart, and you know that there are lots of different causes of palpitations, but for atrial fibrillation, typically people would describe a fluttering sensation or racing of the heart, irregularity, that sort of thing. Once you've got a diagnosis, we can look at then how to treat. And so diagnosis is made in a few different ways. So an ECG would be the commonest way. And an ECG is a paper tracing of the heart. So you have stickers put across your chest, and a computer will take a paper tracing. Now, they're very, very useful. You get a lot of information out of an ECG, but it's a bit like taking a photo with a camera. It will only tell you what's going on at that particular time. It won't tell you what's happening on other occasions. And so for people who have symptoms on other occasions, we would often look at using heart monitors. So you can get, there's all sorts of different wearables. So, you know, from patches that you put on your chest to ones with sort of cables to, you know, these days the new generation of the Apple Watch is pretty good. And these will look to see whether people have symptoms or whether people have atrial fibrillation or indeed some other sort of heart rhythm problem at the same time as their symptoms. Once you made the diagnosis, it's then the treatment is, well, so the assessment is, one is risk, which I've talked about, and the second is symptoms. So people with AF, it's interesting. Some people will have AF and have absolutely no idea they've got it, no symptoms whatsoever, be completely fine. Other people will be very, very symptomatic with, you know, just having noticed a, you know, small amount of atrial fibrillation and really everything in between. So often the symptoms are related to either the heart rate going too fast or too slow. So if people get a fast heart rate, they might feel breathless, they might feel palpitations or chest pain sometimes. If their heart rate's too slow, it's more commonly that you'd feel dizzy, blacking out sometimes, but, you know, dizziness would be the predominant system, and breathlessness sometimes too. And then the treatment depends on what the problem is. So let's say you have a fast heart rate, then the first line might be treatments such as tablets such as beta blockers, which can slow the heart rate down. There are other options, so other tablets that will slow the heart rate down. And there are some tablets which are called antiarrhythmic drugs that can increase the likelihood of the heart staying in normal rhythm. It depends a bit about how long someone has had symptoms. So if you've had atrial fibrillation for years, then it's quite unlikely that you're going to get back to normal rhythm. So often we would just deal with the fast or the slow heart rates. If someone has very recently had atrial fibrillation, then we may well be able to get the heart back to normal rhythm. And so medication might be appropriate. Sometimes we do procedures called a cardioversion, so essentially a controlled electric shock. It sounds very dramatic, but it's really not. So you give someone a sedation and put some pedals on the chest, a bit like you see on TV with a jolt to restart the heart, but it takes 2 seconds with the intention of restarting the heart. And sometimes there are other procedures called ablation procedures, which you can have to put the heart back into normal rhythm. But it's very much dependent on the individual, because these are symptomatic treatments rather than necessarily prolonging life or anything like that. So it really depends on the individual. Where would you like me to go from here? I mean, there's more I can talk on AF, but I think that gives you sort of an overview of it and the sort of high level, how we diagnose it and how we treat it.
I'd like to move on to the next point, which you just touched on, and that's amyloidosis. Well, certainly for me, and I know some of the other guys diagnosed with WM, we have to go away and be checked for amyloid and amyloidosis. I know you're a bit of an expert on cardiac amyloidosis. Could you explain to us what amyloidosis is, and again, what's the problem with it, and how do you detect it, and how do you deal with it?
So it's a huge topic, but I've tried to sort of break it down into different areas, if you will. So firstly, amyloid is a protein essentially, and your liver will produce a protein called, there's a few different ones, but the one in question here is transthyretin. And once this protein gets produced, it can in abnormal states it can dissociate. So it comes essentially as you have it's what we call a tetramer. So it's 4 bits together, and those pieces can dissociate. So 4 becomes 2 becomes 1. And those proteins, then if they get twisted in an abnormal way, then they form amyloid. So amyloid is then floating, so it's a protein that's floating around the bloodstream, and it can get deposited in certain areas. So the heart being one of them. Now, there are different sorts of amyloid, and they are associated with different conditions, but broadly speaking, the commonest are AL amyloid, TTR amyloid, and an AA amyloid. So from the purposes of the heart, TTR and AL are the commonest. So in people with Waldenstroms, as you know, they produce a lot of IgM, so an immunoglobulin that can then stops the bone or other bits of the bone marrow working effectively. So it's pumping out lots of this excess protein. AL amyloid is a very similar thing, and so that's just a different sort of immunoglobulin, but that there are crossovers between AL and an IgM in terms of the predisposition to amyloid. Certainly AL is more common, but there are certainly patients who are reported as having amyloidosis that have Waldenstroms. Now, going back, I don't know, maybe 10, 15 years, we thought that, it was a lot more common to think that Waldenstrom's patients were more likely to get amyloid of the AL type. But actually, with sort of advances in diagnostic technology, we're actually seeing that there are still patients with the TTR amyloid type, and so I'll come on to that in a bit more detail. Now, this protein, as I say, gets deposited in a few different areas. So the heart being one of them, and so typically people who have amyloidosis of the heart, their hearts become thicker. And they become stiffer. So this protein gets, if you think back to the picture I just showed you, the ventricles and the atria, so the muscle becomes thickened, and it becomes less effective because it's stiffer. So your heart should be contracting nice and vigorously like this. If the walls are full of this extra protein, then it just becomes stiff. So it will contract down okay, but then it's really stiff and slow to relax. And so people will often have symptoms of heart failure. The heart might, as I say, might squeeze okay, but it becomes stiff and slow to relax. So people might get breathless. Swelling of the ankles would be the two commonest symptoms, but fatigue, just general inability to do their activities of daily living are all very common. So there are the other places in the body that it can go, and one of the clues, certainly for TTR amyloid, is that it can go into the carpal tunnel ligaments in both wrists. So if you have a patient, it's one of the sort of red flags. I always tell my junior doctors this: if you see a patient in clinic and their heart looks a bit thick when you've done an echo scan, and they've had and there's some other clues on the ECG that looks like it might be amyloid, always ask them, have you had carpal tunnel syndrome? And if they've had carpal tunnel syndrome in both arms, then that is it's like a red flag to say this person is likely to have amyloid. Then you can look really clever, because you can say, oh, but they've got cardiac amyloid, and then of course you're always proven right, and they go, well, how did you know? And it's the clue. There's the clue. And the reason is because this amyloid protein has a sort of a predilection to go in areas where there's a lot of movement. And so, of course, your wrists move a lot in day-to-day life, and your heart moves a lot in day-to-day life. And so that's why it tends to go in those areas. But it will go in others too. So, for example, your peripheral nerves, so the nerves at the end of the legs as well. So people will often get numbness in the legs. It can go in people's guts. And so you get, diarrhea or constipation or alternating. People's tongues, interestingly. In fact, there's something called amyloid tongue that is, you read about in the textbooks. You virtually never see it. And I saw a guy about 3 weeks ago who had an amazing, like really big, thick tongue, and you can actually see the teeth indents in his tongue. I said I can take a photo of it because you just don't see it very often. But the commonest areas would be heart, peripheral nerves, guts, and carpal tunnel ligaments. Now, the key really is to diagnose it early, because if the early, as with most things in medicine, the earlier you find something, the more you can do about it. Wild type amyloid, so this is called TTR. Sorry, let me backtrack. So TTR is transthyretin amyloidosis. So this is a same amyloid but different precursor protein. And so this is typically, we used to call it senile amyloid, not because it was to do with dementia, although amyloid is also the protein that can get deposited in the brain in Alzheimer's. But senile, or we now call it wild type TTR amyloidosis, is typically a disease of older people. There is a familial variant, so there is an inherited version of this, but most cases are, say, this wild type. And that is typically a disease of older people, so often well into their 80s, more commonly men, but not always. It's often incidental findings, so we use the word indolent. It happens very slowly and insidiously over many, many years. I suppose a bit like Waldenstroms often will go for many, many years without symptoms. But if there are some clinical features that would help differentiate, but by and large, once you've made the diagnosis of amyloid, the next thing is this AL amyloid or is this TTR amyloid? And if it's TTR, is it the sort that's inherited, or is it the sort that's just happens as you get older? And traditionally, the main reason for telling the two apart was because AL amyloid, there's more you can do. So the sort of gold standard, let's say, would be thinking about stem cell transplantation. So if you can cut off at source all the extra protein that is being created by having a stem cell transplant, then you can stop amyloid getting deposited in the heart and elsewhere. Now, there are, in the last sort of 5 years, there have been a lot more treatments available for amyloid. There are still a lot more in development. And these are sort of used in different areas of the point between the liver producing the protein and they're getting deposited in whichever tissues it's going in. So there are therapies that are sort of, let's call them gene-based therapies that help to prevent the liver churning out this extra protein. Then there are therapies that help remember I talked about the breakdown of this protein. So there are therapies that can stop the breakdown of this big protein into the little ones that then can get lodged within the heart. But yeah, you need to differentiate it between the two different types first. So how do you do that? Well, to make the diagnosis, the first thing is to have the suspicion. So unfortunately, it's certainly in the case, I mean, I see this probably every month, that I might look at an echo scan. So an echo is an ultrasound scan of the heart and say, oh, look, I think this looks like amyloid. And often they'll have had an echo 2 years ago and it was reported as normal. But if you know to look for these things, then there are often signs from a little while previously. Once you've got your clinical suspicion, MRI is a very good test for this, because it will, you can characterize that it's actually the spaces between the cells, but an MRI of the heart will show up amyloid. It won't necessarily differentiate between the two types. And so then either you have a biopsy, so there you can take a biopsy from the heart or from other areas where there's amyloid. And it has a characteristic look when you look at it under a microscope with a special sort of a stain. There are nuclear medicine scans, things we call them Dpd scan. Dpd is a very long chemical name, which I must admit I can't remember. It's got about 30 letters in. But we're very lucky, actually, in the Southwest, we do have access to that, because for a long time it was the preserve of sort of London centres, but we have access to that locally now. But once you've got the either the scan results or a biopsy, you can then know what you're dealing with and treat accordingly. As I say, there's a paper looking at Waldenstroms and amyloid types, and whereas previously it was thought it was all AL amyloid, actually it's certainly recognised now that TTR might be, you see TTR amyloid as well. Now, is that just coincidental? It's certainly possible. We don't necessarily know the answer to that yet.
Okay, thanks for that, Chris. And I think you've almost answered one of our callers' questions, which was, how often does localized amyloidosis develop into systemic amyloidosis? And are there any commonalities between the cases that do? This particular caller had laryngeal amyloidosis.
Really? Okay. I mean, that in itself is pretty rare. As I say, the commonest sites are heart, carpal tunnels, guts, let's call them, and peripheral nerves. But ultimately, it can go anywhere. There are basically whole body scans that we can perform to look to see where within the body it's been taken up. But yeah, ultimately it can go anywhere. But those would be the commonest sites.
And this is an observation from me, is that you talked about extremities, and a big deal for most of us as WM patients is peripheral neuropathy, which is going to be a subject of a webinar coming up. But I suppose there is some possibility of confusing the two, whether it's amyloidosis or whether it's just a straightforward peripheral neuropathy.
Yeah, I think that's right. You can actually, I mean, if it's related to amyloid, then it will show up on body scans, so you can see the amyloid deposited in the peripheral nerves. So there are ways of differentiating between the two. Okay,
thanks. So changing tack, most of us, or some of us, have been on various. There are various chemotherapy regimes for Waldenstroms, using various different chemicals and stuff like that. Does chemo affect the heart and its function in any way?
So it depends on the chemotherapy. So there are certainly some chemotherapy agents that can affect the heart. So typically some of the drugs that are used to treat lymphoma can affect the heart. And so anthracyclines would be the commonest group of chemotherapy agents that can affect it. And that's why patients who have these agents will commonly be screened as they're having their therapy to look to see whether the heart is maintaining its function. Certainly, I mean, I get a lot of referrals from hematologists for patients who have had some sort of reduction in their heart function, and the question is always, can we carry on or not? Is the bottom line. But at what point do you stop the chemo, or do you reduce the dose, or change the regimen? Now, often that decision relates to how much has the heart impaired. So is it just mildly impaired? Is it severely impaired? And can you start some cardiac drugs to sort of combat the effects of the chemotherapy? So these days, I mean, heart failure, I run the heart failure service for Bournemouth, and it's a very sort of emotive word, but it's one I think and people argue the toss, should you say heart failure? Oh, it's very bad thing to say heart failure, isn't it? But you wouldn't not call cancer because it sounds a bit horrible. That, to me, that's just, I really disagree with that. I think the whole point is we should be advertising that this is an important condition, and in fact, overall, heart failure has a prognosis that's worse than pretty much any cancer you care to mention. And so unless we call it how it is, how are we supposed to educate the public and get people to present and encourage people to take the drugs and so on? But if you get people on the correct drugs and early, you can reverse the effects of these. People can get the hearts completely back to normal. And certainly if they're on chemotherapy agents, you can get them back to normal in a number of cases. It's really quite reassuring from that perspective.
Thank you. And then for some of us, and this is a question that's cropped up a couple of times from our callers, is there's a new drug on well, it's not so new now, for 2 or 3 years now, there's been a drug called ibrutinib that was approved by NICE for us WMers, and quite a few of us are on ibrutinib. Does that have any issues with the heart? A couple of our callers believe that possibly it does.
Yeah, I think the difficulties with a lot of these new sort of biological agents is that we don't necessarily have all the data yet. I mean, it's not a drug specifically that I'm familiar with, and it's probably better aimed at hematologists. I've certainly never prescribed it. And like most of these things, the key is just to monitor as you're on these things. So usually with an echo, but sometimes nuclear medicine scanning to see, has there been any change. But I think we're still feeling our way with some of these newer agents in terms of safety profiles and so on. But I'm not specifically aware with that particular drug. I've got no experience with it.
Okay, thank you. I can ask that question of perhaps Helen McCarthy next couple of weeks' time. Yeah. Another question here: What is the role of anticoagulation in a person with atrial fibrillation and Waldenstroms?
So, if I just deal with atrial fibrillation on its own first of all. So, if you have, I talked about the scoring system we used earlier, and if you have if you have a score of 1 or more, then stroke risk is likely to be more than your bleed. We'd always look at what people's bleeding risk is. Then you're likely to benefit from anticoagulation. And there's a few different ways of doing this. Either, we used to use warfarin, don't really use warfarin very much at all anymore. There are newer drugs called DOACs, which somebody may well be familiar with. So things like apixaban, dabigatran, edoxaban, rivaroxaban. So they don't require blood monitoring and so on. Now, those drugs are very effective at preventing stroke or reducing the risk of stroke. The difficulty with any of these drugs is, what do you do when people have an increased risk of bleeding? And so in people with some hematological problems, either they have some sort of other issue with their clotting, they might have problems with their platelets, and so sometimes people with Waldenstroms might have either abnormal platelets or reduced numbers of platelets because the bone marrow is getting crowded out by the other cells. And in those cases, one has to make a decision in terms of sort of the risks versus benefits of starting a blood thinner. Now, a lot of that will vary on what your stroke risk is. So let's say you're, I don't know, a diabetic with high blood pressure, female who's 80 and, I don't know, has got a leaky mitral valve, then you're going to be very, very high risk of stroke. And therefore you would have a very, very, very low threshold for trying to put a blood thinner on board, and almost to the exclusion of other things. You might say, well, let's give it a go and, and see how we go. Whereas if you're 40, male with no other risk factors, you might think, let's err on the side of caution. So usually those sort of decisions are made between a hematologist and a cardiologist together. So people like Dr. McCarthy will often, we'll write to one another saying, well, what do you think? And we'll come to a consensus view between us about, the risks versus the benefits in that individual. But by and large, because stroke is a sort of, often not quite irreversible, but such a catastrophic bad outcome, we err on the side of thinning the blood down to prevent a stroke. And then, bleeding, whilst often, yes, bleeding can be catastrophic, but by and large, it's more manageable than a stroke. And so, we err on towards that side.
Okay, thank you. Yeah, and I recall in my early days of Waldenstroms, I had rashes on my legs that I couldn't stop scratching, and they would bleed. And I guess if I'd been on blood thinners, that would have been possibly a real problem for me.
Yeah, that's it. I mean, obviously, any of these drugs, they'll cause you to, bleed more, cut yourself shaving, or like say, scratches, anything like that. Yeah, it can be an issue.
Okay. Well, Chris, thanks. We've taken up a lot of your time on Easter Monday here, and I know you've got a busy day ahead of you on the golf course.
Well, I'm not playing till 4 o'clock, so it's at least it's not snowing here like in London.
No, that's true. I'd just like to thank you so much for joining us today. As I say, it's our first one, and I think it's been quite successful, and I hope others watching have. And I do apologise that I haven't been able to answer or ask all of the questions. but I will cover those in other formats. But Chris, for now, thank you so much for joining us. We really appreciate it. And I know I speak on behalf of WMUK when I say that. And I see a couple of thumbs up there and applauses. So thank you so much for joining us.